We will now take a question from Dawn from Brecksville. Dawn?
Okay, thank you. Thanks for taking my call. I speak with your staff regularly and give them my opinion so that you accurately represent me. First of all, I worked in managed care for 13 years, and the plan that you're talking about is a public plan. The public option has been tried in many other states as well as other countries, and it has failed. And it has been very costly in terms of funding. So when you called it budget neutral, I just found that a little amusing. In Canada, I know that they had said that their health care, the Canadian medical director, said their health care system is imploding. Now, we just learned from the past and going into the future. Their former president of the Canadian Medical Association, said that the doctors overwhelmingly voted for change because they can't stand their own health care system. They stated the biggest problems, which are actually the problems that happen in managed care along with the regular public option, are problems with access. And they have no family doctors, they have too many cases, and treatment becomes too costly, which then results in rationing. He mentioned that they have 1 million people waiting for surgery. They have another 1 million waiting to see a specialist for surgery. So when you look at the cost that they're spending, and it was stated that it was 42% of their total spending was on health care, and in Britain it's the third largest employer behind the Chinese Army and the Indian Railroad. 70% of Canadians have had to have additional private insurance just to cover prescription and emergency appointments. And by the way, you mentioned about illegal aliens. We provide in the United States help to anybody who walks into a healthcare facility. So it's a little disingenuous to say that they would not be impacting our system. Canada was also rated at the bottom of 29 countries in terms of value for money paid. What I'm concerned about most, Ms. Sutton, is that the bill will be slipped in the middle of the night or 11th hour, and somebody will put things in that shouldn't be there, and there won't be any oversight. You stated the plan would not force people into the government plan, but once again, when the government controls the purse strings and all the initiatives that they can control the outcome.
Did we lose Dawn? I think we lost her, but you could go ahead and answer her question.
Oh, Dawn, I'm sorry that something happened, but please, I want to hear the rest of your questions. But in the meantime, let me address some of the issues that you raised, and I appreciate your call, and I appreciate your calls to our office that you said you make. So, a couple of things. First of all, you spoke about in some at some length about Canada and the program in Canada, which is a single-payer system. The bill that we are considering, H.R. 3200, is not a single-payer system reform. A single-payer program has one administrator of health care benefits, and that is not what we're talking about. Quite the contrary. We're actually taking a solution that builds on the private insurance system, and it just injects patient-centered reforms to that system that remove the insurance industry's ability to deny coverage and care, and we do that through the injection of another option people can choose. So this actually expands opportunity in options for people to choose, as opposed to consolidating everything into one single payer system. So those concerns about Canada, and you mentioned doctors being concerned about rationing of care under the Canadian system. It might be important to recognize, or for me to mention, that the American Medical Association does support this legislation. So our doctors here do not, at least those who are represented by the AMA, and the AMA in their form as an entity, they support H.R. 3200. So I think it's important to clarify that what we're doing here is very, very different than what we see in Canada in the system that they have in place. Totally different thing. You mentioned that you are skeptical of the deficit-neutral nature of the bill, but all I can say is that the Congressional Budget Office has has said that this bill is deficit neutral over the 10-year budget window, and in fact, it even produces a $6 billion surplus. CBO estimates that more than $550 billion in gross Medicare and Medicaid savings under the reforms, and under the bill, it includes a comprehensive array of delivery reforms that set the stage for lowering the future growth in health care costs. So not only are we talking about deficit neutrality of the bill itself, we're talking about reducing the growth of health care costs for in the future that have been spiraling unbridled for so long. So that $1,800 a year that everyone is being asked to pay in additional health care costs to covering the spiraling costs will be curved downward, and will be eliminating that hidden tax of $1,100 per year that you were mentioning, that you help people as a care provider when they show up for help. And if those people aren't insured, then that $1,100 that we're all paying through our premiums and the cost of our premiums will no longer be that hidden tax. We are going to be eliminating the way that is working under our current system. So I really appreciate your call. And on the issue of illegal aliens, I believe that I already read the specific language in the bill. And if you have additional suggestions, then please call our office, and I'd be happy to consider them.